you so
Wait 1 second.
Good morning. Welcome to MGH Neurology Grand Rounds. Today, our speaker is Dr. Rebecca Gottesman, MD, PhD. Dr. Gottesman is a stroke branch chief and senior investigator of the Stroke Cognition and Neuroepidemiology section at the National Institutes of Neurological Disorders and Stroke, intramural research program at the NIH in Bethesda. Dr. Gottesman completed her undergraduate and medical training at Columbia University and her internship and neurology residency, as well as vascular neurology fellowship at Johns Hopkins. He completed a PhD in clinical investigation at the Hopkins Bloomberg School of Public Health and was professor in the departments of neurology and epidemiology, as well as a core faculty member in the Welch Center for Prevention, Epidemiology, and Clinical Research at Johns Hopkins prior to her move to NINDS in 2021. She maintains an adjunct professor faculty appointment at Hopkins. Her research focuses on the vascular contributions to cognitive impairment, dementia, and Alzheimer's disease, as well as cerebral small vessel disease and post-stroke dementia. She primarily studies large epidemiological cohorts with leadership roles in the ERIC study and the discovery cohort, and uses neuroimaging to evaluate mechanisms related to these research questions. She also studies disparities in stroke, dementia, and post-stroke cognitive impairment. She won the 2019 Outstanding Stroke Research Mentor Award from the American Heart Association and is an elected member of ASCI. Please join me in welcoming Dr. Gottesman.
Thank you so much. It's great to be here and to see some familiar faces and lots of new faces as well. So I'm going to talk to you a bit today about preventing dementia by preventing stroke. So I'm a stroke neurologist, as you just heard, and I want to make a case that what we do when we think about how to prevent stroke is highly important and potentially impactful in modifying risk for dementia. And this is not only because stroke itself can increase risk for dementia, but really importantly, the risk factors for stroke are really important for dementia as well. Oops. So here's my requisite, there's her code for attendance for CME. And I have no disclosures, as you can see here, no financial relationships. This audience certainly knows that dementia is a massive growing public health epidemic, both in high-income countries and certainly in low and middle-income countries. We expect rising rates of dementia broadly. And again, dementia as a broad term refers to the cognitive impairment and impact on daily function that we see in patients, Alzheimer's disease being the leading cause of dementia. This bullet, I forgot to tweak a little bit because certainly there have been changes in terms of therapeutics, but I would argue they are not a slam dunk either in the therapeutic benefit nor in their accessibility to the population. Certainly there are now some new treatments that look promising in Alzheimer's disease, but we have a long way to go. And importantly, it may be that addressing sort of direct therapies targeting amyloid, for example, might not be enough to fully solve some of this problem with the growing public health epidemic. So really what I'm going to focus on, and what I mean when I say that's not going to solve all of the problems, is that there's a tremendous amount of overlap between vascular disease and Alzheimer's disease. So we know that patients who are clinically diagnosed with Alzheimer's often have some vascular contribution. And similarly, the concept of vascular dementia, which I put in air quotes because I think it rarely exists as a pure entity. Many of those patients also have some AD neuropathologic overlap. We know that patients with AD who are clinically diagnosed with AD have a high prevalence of traditional vascular risk factors. And this Venn diagram doesn't quite do justice to the amount of overlap, but I needed enough room to put the words vascular dementia and Alzheimer's disease. But really the overlap is probably much bigger than the separate parts. And what we don't really know with this observation that vascular risk factors are present in people with dementia and with AD specifically is that because vascular disease directly impacts some of the neuropathological processes that lead to Alzheimer's disease and dementia broadly, but Alzheimer's specifically, or is it just that if you have both are common things, vascular disease as well as neurodegeneration, Alzheimer's disease, you're more likely to decline to a point that you're clinically labeled with AD. And that's something we really don't understand that well. In addition to this co-occurrence of vascular risk and Alzheimer's disease, we know that many AD patients on autopsy, about 3/4 of AD patients have some vascular changes in the brain. Certainly that's common in older people anyways. And similarly, if you look at patients who have an equivalent amount of cognitive impairment before they die, those who have more vascular changes have less AD neuropathologic changes to get to that equivalent level of cognition. And again, in postmortem studies, it's a little challenging because lots of things happen right before death. Certainly, stroke happens right before death occasionally in people who are very hypotensive. But a lot of these studies try to account for excluding those very, very late, very recent pathologic changes. This is just one of the analyses from Julie Schneider's group, the Ross Mack studies, who've really been the most impactful in looking at postmortem studies in people and understanding mixed pathology, where they looked at individuals who had a clinical diagnosis before death of MCI or probable Alzheimer's disease. And I just, all the details might not be that visible here, but you can see, looking at different pathologies, that I guess you can't see my cursor, so I'll stop using it to point, that AD represents a relatively small proportion of the total pathology. So again, clinically, they were felt to have AD or MCI, and on autopsy, they have a mix of AD, infarcts, Lewy body, et cetera, and a smaller proportion of really pure AD. Again, making this case that my Venn diagram had a pretty big overlapping area for vascular and AD. We know, so I'm a vascular neurologist and epidemiologist. I'm not going to pretend that I'm the person doing a lot of the really important work on the more basic translational side here, but there is good evidence that there are plausible mechanisms linking vascular and AD mechanisms. So we know that over time, vascular risk factors, will alter blood vessels and alterations in blood flow, especially in the white matter. Right. There we go. And we know the blood-brain barrier may be a very important factor that might be disrupted in the presence of vascular disease. In addition, the neurovascular unit itself can not only be damaged by vascular disease, but by A beta itself. And certainly, I'm going to refer to amyloid at several points throughout this talk. By no means do I intend to argue that amyloid is the only important factor in the development of Alzheimer's disease, but certainly is an important player, and we know is an important pathogenic step leading to Alzheimer's disease in terms of its accumulation. And then this concept of the lymphatic system and clearance of toxins. So vascular disease, we know, may directly impact that clearance, either through sleep-related mechanisms or more directly, and might impair clearance of A beta and other brain waste. So because of this overlap between vascular risk and Alzheimer's neuropathology, and because even if we're making a little bit of progress looking at Alzheimer's specific treatments, we're not going to solve the whole problem because of this great contribution of vascular disease. In addition, one of the biggest challenges in Alzheimer's disease treatment is this very long preclinical period. So we know that patients develop symptoms often decades after they've started to have neuropathologic changes. So the typical Jack curve showing the onset of clinical symptoms are often decades after you have increases in tau and amyloid. So the problem is that if you start to treat people at this time point, we're going to be very challenged in actually making progress in decreasing the disease progression and certainly in preventing disease. So the appealing thing is what do we know that's important in this early period? And it looks like some of the earliest changes, this sort of line here is hypothesized to be vascular dysfunction. So vascular risk, I've told you that it overlaps a lot. We see a lot of mixed pathology. But importantly, the relationships between vascular risk factors and vascular disease with Alzheimer's and dementia more broadly appear to be strongest when we start earlier in life, in midlife. And I'm going to show you some evidence of that. So really, this is appealing as a target for prevention, not only because it's something we know how to treat and prevent, we know in theory how to treat high blood pressure, diabetes, et cetera, but because it's especially important at an earlier time point, which might target early parts of this pathogenesis of AD. So the title of this talk is Preventing Dementia by Preventing Stroke. So I already sort of said at the beginning that part of the way that I think this is important is because literally stroke may sometimes lead to dementia. So if someone doesn't have a stroke, we may eliminate that subsequent dementia or cognitive impairment that they have. But I think it's important to sort of establish how we know that, what we know in that area. In addition, once you've had one stroke, has the ship sailed? Is secondary prevention important? What do we know in that space? In addition, if we then take a step back, what about preventing that stroke in the first place? How can that prevention, thinking about primary prevention of stroke, how can that actually prevent dementia? And again, referencing this midlife window and the importance of the life course, is there a particular key time period during which treatments might have to be implemented to have an impact? So preventing stroke, all of you that are, clinically doing stroke or have spent time on stroke service certainly know that these are sort of the main guidelines. Obviously, when you see someone come in with a stroke, you're thinking about secondary prevention. So this is not the group that's thinking primary prevention, but you know that these are important areas that we focus on when trying to highlight ways to prevent stroke. So I'm going to talk about what we know in some of these areas and what we know about the relationship with dementia. So first, more broadly, from a sort of ecologic study perspective, we know that stroke death rates and stroke rates are highest in the southeast part of the country, in the stroke belt. And this has been observed in multiple studies. The REGARD study is really trying to understand what it is in these regions and what might be intervenable targets. But in this really lovely work done by Paula Kilsand, she looked at people who were born in a high stroke mortality state and basically showed that those people had higher rates of dementia than people who weren't. So again, this is not accounting for individual risk factors, individual treatment, et cetera, but simply if we superimpose the map of dementia, we might see an increased risk in the same area. So stroke belt and maybe perhaps dementia belt as well. In general, so this is work led by Sylvia Catone at Tel Aviv University. In general, we know that stroke rates have gone down over time in the general population. So this is looking in the ARIC study. I'm going to tell you a lot more about ARIC soon and tell you what the study is and the kind of data we have, but just to sort of set the stage here, in the ARIC, we see that in general, stroke rates have gone down over time, so has stroke-related mortality. Not so much in the younger population, and again, this is the younger part of a now older cohort, but this is potentially concerning in terms of the future and people potentially developing cognitive impairment down the road. But in general, reduction in stroke, which is paralleled by reductions in dementia rates. So again, more evidence on a broad scale, both the ecologic data that I showed you and then sort of pairing these studies here, reductions in stroke, reductions in dementia. This is work from the Framingham study showing that over time, there have been reductions in dementia rates, excuse me. And this got a lot of press when it came out, and the thought was, well, we have better blood pressure control, fewer people are smoking. It's likely motivated by differences in vascular risk control, but hasn't really been all that well teased apart, nor has it really translated into interventions that will clearly have subsequent decreases in dementia rates. Okay, so I told you I'd tell you a bit more about ARIC. So ARIC is the Atherosclerosis Risk in Communities study. This is a cohort of nearly 16,000 people. It was started in the late 1980s when people were middle-aged, and you can argue with me that some of this doesn't quite count as middle-aged, but this is our sort of closest representation of middle-aged. And although now we're actually finishing visit 10 and about to start visit 11 in a few months, for the purposes of today's discussion, I'm going to mostly talk about data through visit 7. So the visits occurred every few years, then there was a gap. During the entire time, people are called by phone annually. Now they're called semi-annually. And in visit 5, which was 2011 to 2013, we started what's called the ARIC neurocognitive study, where we included a much more expansive, much more comprehensive neurocognitive assessment. We had sort of shorter cognitive battery, 3 tests at earlier time points in everyone. Everyone seen at visit 5 had a much longer battery, which included informant interviews, expert classification of MCI and dementia, in addition to the cognitive testing. And then a subset of people also had brain MRI, both in an earlier ancillary study and also as part of this NCF visit. Less than half of those have had repeat scans. Right now, as part of our current visit, we're doing another 1,000 brain scans, including 4 beta pure PET. So I started our PET study just after visit 5, which was recruiting people from 3 of the 4 ARIC sites who did not have dementia, to evaluate this relationship between vascular risk and amyloid that I sort of alluded to at the beginning. Why do we see this overlap? Is there a direct relationship between these two? And now we're repeating another 1,000 fluorobeta-pure PET scans. So fluorobeta-pure binds to amyloid. These are the 4 sites of the country. So they all represent a combination of rural, urban, Black, white populations primarily. And when we look at cognition, I'm going to share some data that looks at cognitive change over time, as well as incident dementia we have multiple methods for surveillance, both the in-person classification with informant interview and expert review, as well as people who don't come in, but we talk to them by phone for cognitive assessment and or informant interview, as well as some cases identified through medical record hospitalization codes, just to be able to have surveillance over the entire cohort, and that's ongoing going forwards. I do want to point out to those of you that are epi nerds like me, we do think a lot about attrition in this longitudinal follow-up. Any cohort that you follow for decades, you're going to have dropout due to death, due to other disease. And we know that in general, the risk factors that I'm most interested in, things like hypertension, diabetes, and middle age are the things that make you least likely to survive to a later time point, but also may put you at highest risk for the outcomes I'm interested in. So we have to think about that, because otherwise you'll underestimate those associations if the most at-risk people don't survive to experience the outcome they're interested in. So we use both multiple imputation change equations as well as inverse probability of attrition weighting depending on the analysis. So Silvia Cotone again did this work. First, I just want to establish that first question. Stroke itself, I told you, is a risk factor for dementia. How do we know this? What do we know about this? So in this particular paper, we looked at individuals in the ARIC cohort. So ARIC was designed to look at the natural history of atherosclerosis and its risk factors. So there's very careful surveillance for cardiovascular events, including stroke, over the entire cohort follow-up. And basically, we looked at stroke events. Sylvia led a project going back to extract NIH stroke scales from the charts of all of these stroke events so we could look at severity. And what we found is that individuals who had no stroke have the lowest rates of dementia, better dementia-free survival here. Those with one stroke that was more mild had an in-between amount, and those that had at least one severe stroke had the greatest risk of dementia. So what we would expect, but not something that had been sort of clearly shown on a population basis like this. And similarly, not only is severity important, but recurrence is important. So this goes back to my earlier comment. Once you've had a stroke, has the ship sailed? Is it important to think about secondary prevention? And the answer is yes, because recurrent strokes, although I do acknowledge that that may simply reflect worse baseline vascular health of the individual, this is adjusting for those risk factors. But regardless, having at least 2 strokes increased your hazard more than having 1 stroke. And if you have at least 2 strokes and at least one of them was a moderate to severe stroke, your hazard of having dementia went way up. So recurrent stroke is bad, severity of stroke is bad, the combination seems especially bad. And again, this is adjusting for underlying vascular risk factors, but we know there's other things that contribute to why someone has recurrent strokes. Deb Levine, who's at University of Michigan, looked at this question as to how secondary prevention might impact cognition. She has 2 consortia that pool multiple epidemiologic cohorts. One is the BP-COG consortium, and this is the stroke-COG consortium, where she pooled multiple studies, and we're still doing a lot of the early aims related to this particular grant. But basically found that in people with stroke, across multiple cohorts that were pulled together, of which ARIC is one, that mean fasting glucose level post-stroke was an important determinant of cognitive function. So this line at the bottom is the people whose mean glucose is 166, and you can see that they had the steepest decline post-stroke. So this is not necessarily indicating that these are people who went on to have another stroke, but really their glucose control being less well controlled appears to be important in their cognition. We did not find a similar relationship for blood pressure or cholesterol. That doesn't mean that they're not important. I'm going to make a case soon that blood pressure is really important, but from midlife and over decades. So this may be because it's simply a little late to already be intervening with cognition if you look at someone after they've had a stroke. Okay, so if this is a basic schematic of how I think about things, vascular risk factors can lead to cognitive decline and dementia, potentially by a stroke, potentially by a sort of silent changes or even volumetric changes that we see on imaging, and I'll throw a few other things as we go along. I want to first start off sort of making a case about what we know about vascular risk factors and cognitive decline. So again, stroke is an important risk factor for dementia, but let's see, what if we even prevent that stroke in the first place? What's the importance of these risk factors? So Andrea Schneider and Andrea Rawlings both led work looking at this, and again, focusing in ARIC on that midlife time period. So in ARIC, we looked at hypertension in midlife, and this was the older definition of hypertension before they got sort of modified recently, but basically showed that people who were hypertensive in midlife had a steeper decline in cognition over 20 years, independent of other risk factors, certainly independent of age, which are to cognitive decline. But importantly, hypertension in later life was just not that important for how your cognition had declined over time. So really midlife was especially important. And this is just showing you some of the trajectories of blood pressure levels and different cognitive scores. So here's a global cognitive test. These are these 3 other tests that we looked at even before that Visit 5 ARIC neurocognitive study. I do want to point out here that we lose a relationship here mostly because people that had a systolic blood pressure of 170 in midlife, there were very few of them that were still alive 20 years later to explore these relationships with cognition. So these are really wide confidence intervals. Andrew Rawlings looked at this with hemoglobin A1C, both among diabetics and non-diabetics, and found that your higher hemoglobin A1C, again, this is in the non-diabetic range, this is in the diabetic range, was associated with more cognitive decline. And I want to point out these pairs of estimates here show the effect of that adjustment for attrition that I mentioned earlier in terms of methodology. So just to point out, if you don't consider attrition, these are these sort of circular estimates as opposed to the square, the relationships look weaker. And again, because people who are most likely to have the bad outcome aren't able to stay in the study because they die or get sick in other ways and can't follow up, you're going to underestimate the relationship. So this just shows how thinking about that attrition is really important methodologically in these longitudinal studies. Other stroke risk factors, so lipids, certainly we think of hypertension as generally a more important risk factor for most stroke. And similarly, we see that hypertension is a more important risk factor for dementia and cognitive decline as well. Melinda Power, who's now an associate professor at GW, did this during her postdoc with me and basically showed that elevated lipids were associated with worse cognitive decline, not nearly as much as we see with other risk factors like hypertension, and certainly not as much as we see with an ApoE4 allele. I do want to point out that the effect sizes in general, even for hypertension and for lipids, et cetera, are not massive, but this is such a massive public health problem. So many people in the population have hypertension that even if it's an incremental change, an incremental tweak in their slope of their cognitive trajectory beyond what we would see with age, that impacts a lot of people. And if you're one of those people that it pushes you below the threshold to diagnose you with dementia, then that's obviously very impactful for those people. AFib, another important risk factor for stroke. We see, this is data from the cardiovascular health study showing that basically after the time of a new diagnosis of AFib, we see cognitive decline fall off independent of at least clinical stroke events. There's some mixed data on whether much of this change in other studies is explained by silent embolic appearing or silent cerebrovascular disease, but certainly we see in general that AFib is associated with more cognitive decline. What about dementia? So I told you that we looked at both cognitive change as well as dementia in the ARIC study. And I just want to sort of briefly mention why I think it's important to look at both of those kinds of outcomes in these kinds of studies. So cognitive change is very appealing because number one, you can detect subtler differences that don't reach the threshold of dementia. But actually, more importantly, from my perspective, cognitive change is generally a less confounded outcome. So if you look at repeated cognitive tests over time, we know that in general, the slope is less influenced by other factors like education, occupation, et cetera. We have data showing that education, people with higher education have higher cognitive performance, but your slope of decline is the same regardless of your educational level. So that suggests that thinking about cognitive change as an outcome is less confounded. We can look at true relationships between risk factor, hypertension, for example, and the cognitive outcome if we're looking at cognitive change. That being said, from a public health messaging perspective, dementia is much more understandable to people. And if we're trying to communicate to the public why they should track their blood pressure in midlife and why they should try to control these risk factors, to say your slope of cognitive change is going to be steeper than it would be from age alone, it's going to be meaningless, right? So thinking about dementia is really important. So when Aaron looked at dementia, and I told you we had multiple ways of surveillance of dementia, but basically using all of those methods, we found that hypertension, smoking, diabetes were associated with dementia in all of these, all adjusted for each other. Not a huge effect size. This is more like what we now call stage 2 hypertension. This is the earlier definition. Actually, pre-hypertension has a similar relationship, which is our current stage 1 hypertension, where we see an increased risk of dementia. Diabetes, this is a massive effect size. I mean, the ApoE effect size of having one E4 allele is close to 2, and for diabetes, it's 1.77. I think it's massive because it's something that in theory we know something about how to treat and prevent. And it's having a huge effect. Again, this is focusing on midlife levels of these risk factors, high risk associated with subsequent development of incident dementia. We did see separate relationships for BMI and cholesterol, but there's sort of BMI is a little tricky. Certainly midlife, we expect higher BMI to be associated with dementia. There's the concept of the obesity paradox that probably many of you are familiar with, where it looks like in older age, obesity looks protective. It's a little, I don't want to spend a lot of time getting into detail about that. The fact is, when people start to have dementia, they may lose weight. So it's sort of this unexpected, this paradoxical relationship. In addition, I told you that life course was important and thinking about midlife was important. So this led us to think about what about change in risk factors over the life course. So Keenan Walker, who was a postdoc with me and now is a tenure track investigator at the NIA, looked at this in terms of blood pressure patterns in the ARIC cohort over time. And basically, he hypothesized that people who were sort of chronically hypertensive, we knew would have a high risk of dementia, but we were especially worried about people who had been hypertensive earlier in life and midlife and then became hypotensive later in life. And certainly we know that people's autoregulatory curves are going to be shifted if they're chronically hypertensive. And so the concern is, do you get into a dangerous zone if someone's blood pressure gets too low? And that's actually exactly what we found. So here you can see this blue line with the highest dementia probability is people who were hypertensive in midlife and hypotensive in late life. And I will point out that almost all of those people were on antihypertensive medications. So this is at least to a great part iatrogenic. And you could argue some of this might have to do with heart failure, where people might need to be on meds, even if their blood pressure isn't elevated. But I do think we have to think about someone's prior pattern before we group them into a category in terms of what their blood pressure should be, especially when they're older and more frail. So hypertension followed by hypotension is most harmful. And again, this is sort of showing similar data, just looking at their age, just showing it's even more pronounced in the people that were closer to midlife at the time of their hypertensive, when they had the higher blood pressure. What about other less sort of traditional stroke risk factors, but still risk factors that we think are especially important in thinking about stroke risk and dementia risk? Michelle Johansson, who's an associate professor at Hopkins, looked at this with atrial cardiopathy. So as many of you know, atrial cardiopathy is of particular interest as a potential risk factor for stroke. The Arcadia trial was trying to understand the role of anticoagulation in the setting of atrial cardiopathy and was a negative trial, but there's still sort of secondary analysis underway. But she found that people with atrial cardiopathy had a greater risk of dementia than people who, this is dementia-free survival, than among people who didn't have atrial cardiopathy. And Wendy Wang at University of Minnesota looked at this similarly by measuring specific left atrial function and size markers and found, for example, this is left atrial reservoir strain, and we see that people with greater proportions here have less dementia. So we see higher risk of dementia in association with the left atrial measurement. In addition, I sort of threw up that primary prevention slide. Physical inactivity is a risk factor. Priya Palta here has looked at leisure time physical activity and found associations. People that have more leisure time physical activity, especially in midlife, have less dementia. We see inconsistent findings on diet, and certainly this is something that there's a lot of exciting new studies going on looking at the fine diet, trying to understand the potential role of dietary interventions in a trial setting. We've seen inconsistent data in our observational data, and then that's sort of been shown in other studies as well. Okay, so vascular risk factors, I hope I convince you, are associated with cognitive decline and dementia, but mechanistically, what do we know about what might actually be going on that could explain this relationship? So one possibility is simply that these risk factors lead to stroke, sometimes lead to subclinical changes in the brain. Those can lead to cognitive problems. It's also possible that you may downstream from a stroke or subclinical stroke have volume changes, brain structural changes. May or may not be biovascular changes could occur in relation to hypoperfusion, for example, other inflammatory events that might lead to brain structural changes. And then finally, this possibility that I alluded to earlier, which is that vascular risk factors, especially in midlife, might directly impact Alzheimer's neuropathologic changes themselves. And then that in turn would impact cognition. So first, subclinical vascular changes. So Gwen Wyndham at University of Mississippi Medical Center looked at this in relation in the ARIC study to silent cerebrovascular disease. So she basically showed that people who had in midlife, and this is sort of later midlife because we don't have an MRI at the first visit, had basically silent lacunar infarcts and white matter hyperintensities, had more cognitive decline. And if you had both, your cognitive decline was even steeper, as you can see here at the bottom. And you can see for white matter hyperintensities alone, we also see a relationship. So not unexpected, but again, a potential mechanism linking these two. These are adjusted for the vascular risk factors, but we know that people with a lot of vascular risk factors, especially hypertension, have more of these changes. In addition, Melinda Power showed that these similar risk factors, including high blood pressure in midlife, was associated not only with more white matter hyperintensities and more progression of white matter hyperintensities, but worse white matter integrity on diffusion tensor imaging. And then Priya Palta looked at this with physical activity, showing similarly with physical activity, people had less leisure time physical activity, had smaller brain volumes, especially in regions typically involved in Alzheimer's disease. And then again, this pattern of high blood pressure in midlife and lower blood pressure in late life appears to also be associated with smaller brain volumes. So again, a suggestion of a potential mechanism. There's many things that can happen in between, but we do think that we might see surrogate markers at some point along the pathway here. So what about direct evidence of relationships with Alzheimer's specific changes? I will reiterate that when I say amyloid deposition, I don't mean to say that's synonymous with Alzheimer's, but I do think it's an important factor in understanding how vascular risk affects cognition and dementia. So the ARIC PET study, which I mentioned, was an ancillary study where we looked at people from 3 of the ARIC sites who did not have dementia to understand how vascular risk was associated with amyloid deposition. And they weren't selected on the basis of vascular risk. It's just information that we have in this cohort. And what we found was we looked at individual risk factors in midlife. We did basically not see relationships between vascular risk factor presence and amyloid deposition, with one exception, which was ironically BMI. And I say ironically because that was one that I told you was not associated with dementia. But here we see higher BMI in midlife was associated with increased odds of elevated amyloid using floor beta PET. And then in late life, similarly, we do not see relationships between vascular risk factors in late life and concurrent amyloid deposition. But we thought about this and really felt that generally these risk factors don't occur in isolation. Certainly we know when we have a patient coming with stroke, they end up going out on 5 meds, not because they're all affecting one aspect of risk, but because they have hypertension and hyperlipidemia, and there's multiple risk factors that co-occur. So we wanted to understand how your burden of vascular risk factor volume really affected your odds of amyloid. So we simply did a tally of how many risk factors you had in middle age, and then we looked at that similar tally at later time points to look at relationships with amyloid deposition. And what we found is that people who had at least 2 risk factors, and we looked at hypertension, diabetes, smoking, obesity, and high cholesterol as our 5 risk factors, people who had at least 2 of those had a greater odds, nearly a triple odds of having elevated amyloid. If you had one of them in midlife, your odds went up nearly double compared to people who had no risk factors. I will point out again that we truncated this at 2+ because there were relatively few people with 3, 4, and 5 risk factors in middle age who survived to be in our study of non-demented people decades later. So this is sort of reflective of the distribution. Interestingly, when we looked at the same burden of vascular risk in later life, so getting further away from midlife, you can see that the relationships get weaker and weaker and then go away completely. Further evidence that midlife is especially important. We don't see the same relationship between vascular risk factors and amyloid when we measure them later in life, but midlife appears to be especially important. And I also want to point out that the relationships appear slightly different when we look at genetic status as well. So really the question here was, is there a two-hit process going on if you have vascular risk and elevated genetic risk, in this case in the form of having ApoE4 allele, is your risk of amyloid greater? And the answer is qualitatively yes, these are statistically not different. So I don't want to get too carried away, but this is among E4 carriers, 2+ risk factors, and at least one E4 allele. Your odds is 9. Compared to people who didn't have any E4 alleles where it's not as elevated. And this is just showing you that relationship for blood pressure in particular, midlife blood pressure, E4 status, having at least one allele versus not having any. Relationship is pretty flat with amyloid SUVR, whereas if you have an E4 allele, there's a pretty strong relationship. So again, something we need to think more about, is this a population that we especially need to target in terms of vascular risk? Other evidence that Alzheimer's specific processes may be related to what's happening with our vascular risk factors. Keenan Walker looked at this with white matter hyperintensity. So again, the question here, if we know vascular risk factors are associated with white matter hyperintensities and other silent cerebrovascular changes, and we know those are associated with dementia, is this one way mechanistically to link these, is to understand the relationship between white matter hyperintensities and amyloid. And he did find evidence that higher white matter hyperintensities were cross-sectionally associated with elevated odds of amyloid, especially in Black participants. And this is, again, adjusted for other risk factors and other demographic factors. Derek O'Kine, who was a post-bac ERTA in my lab, and shout out to the former post-bacs that I know of at least one in the room, not in my lab, but at some point, looked at this with microbleeds. So this is a specific question. So microbleeds are tricky because they're a form of small vessel disease and certainly are important if we think about the overall mechanism by which vascular risk might impact Alzheimer's risk and dementia more broadly. But there's also this particular consideration of cerebral amyloid angiopathy and how that might change some of these relationships. So we really wanted to understand if in a non-CAA type pattern, for instance, mixed microbleed presence or subcortical microbleeds, we saw an elevated amyloid pattern. And the answer is we didn't. We saw what we expected, which is people who had cortical lobar microbleeds and or superficial siderosis on their MRI imaging. Again, these were asymptomatic people in the community. Those people who had that pattern do have elevated amyloid, but the mixed pattern or the subcortical pattern was not associated with elevated amyloid. So again, some mixed evidence here as to what types of small vessel disease might mechanistically be important, and how to understand who's at risk for elevated amyloid. Similarly, for intracranial atherosclerosis, we have black blood MRI measures of intracranial vessels in ARIC participants who have brain MRI at visit 5. In Bruce Wasserman's ancillary study, we looked at relationships between ICAD, an important stroke risk factor, and amyloid, and basically found no significant associations. But again, this sort of hints that in ApoE carriers, and E4 carriers, there might be something going on. I think our numbers are too small here of people that actually had clinically significant ICAD, but people who have elevated evidence of plaque, as well as, and I need to clarify, evidence of atherosclerotic plaque, because we're talking about amyloid plaque and atherosclerotic plaque. People who had evidence of atherosclerotic plaque in an intracranial vessel and who had an E4 allele seem to have a higher odds of amyloid. But I'm not quite sure what sense, why posterior circulation. I think it's more reflective of atherosclerotic burden in general. We need to understand a lot more about this. We see something similar in carotid IMT measurements, which is the combination of high carotid IMT and an E4 allele appears to increase your odds of amyloid in particular. So we need to understand a little bit more about what this means and what this means long-term in terms of cognition and dementia. So finally, obviously I've been trying to make a case that these risk factors are important. The title of my talk is Preventing Dementia by Preventing Stroke. Do we actually know anything about treatment and prevention and if it makes any difference in reducing dementia rates? So theoretically, There's a lot of support for this concept, but practically there is not so much support. That's the punchline. So the Lancet Commission had a recent update to the recommendations about preventing dementia, and they focus really nicely on this life course. I've talked about midlife and hypertension, for example, obesity. They put diabetes here under late life. I would argue it's also important in midlife with our data. But this is really valuable to look at the whole life course, and they estimate the proportion of dementia cases that are attributable to these different risk factors. So Mark Lee at University of Minnesota tried to quantify this even more using ARIC data, and basically saying, using ARIC data as well as some other census data, that if we look at these risk factors that the Lancet Commission identified, how many cases in the US are actually modifiable? And the tricky part here is that most risk factors, if you want to modify it, it doesn't go away completely. You can't use your magic wand and say, let's get rid of hypertension. Obviously, it would be great if we could, but we can't do that. So thinking about incremental reduction in risk. And so first of all, we found that 41% of dementia cases in the US are estimated to be attributable to these 12 risk factors, with much of the burden on hypertension, obesity, and physical inactivity. And if you reduce each risk factor by 15%, dementia rates would go down by 7%. That's a lot of people. And these population attributable risks are even higher for Black and Latinx Americans. So really important to think about modifiable risk. And even if we make progress thinking about amyloid-specific therapies, for example, this is still going to be a massive problem contributing to our burden of dementia overall. So what about specific evidence for treatment? So that's sort of more argument that it's important to think about prevention. What do we know? Again, most studies have been pretty negative to date. There have been a lot of trials looking at interventions, treatments, a lot of these risk factors that haven't been successful. SPRINT and SPRINT-MIND looked at aggressive blood pressure control versus sort of standard blood pressure control, controlling people to below 120 systolic. It was stopped early for a cardiovascular benefit, which means it probably didn't have enough time to accrue events for the secondary outcome, which was the brain benefit, looking at SPRINT-MIND. So SPRINT-MIND was focusing on reducing probable dementia in people with more aggressive blood pressure control versus not. It failed to meet its primary outcome, but it did show a reduction in a composite of MCI and dementia for people that had better blood pressure control and for MCI alone. As you can see here with these hazards, but the probable dementia was not significant. And I fully admit that I thought SPRINT-MIND would be unequivocally negative because I thought it was too short of a time period to show a benefit. So I've been making this case that midlife is really important. We need to treat people early. Why would it help to treat them when they're older for a few years to actually reduce their dementia? But the fact that we see anything and that we see a suggestion here, to me, is pretty exciting. No one will ever be able to fund a trial that lasts 30 years and treats people's blood pressure from midlife through older age. So we'll never have sort of comparable clinical trial data. There's a lot of work in the field thinking about surrogate endpoints and other outcomes other than just dementia to shorten that time window. But this is exciting, even if it didn't quite put the nail in the coffin, so to speak, in terms of the effective hypertension management on dementia. What about aspirin? We're talking about stroke, preventing dementia by preventing stroke. Basically, no evidence at all that aspirin reduces risk of dementia. As we look at this in primary prevention, these are as overlapping as you can get. No benefit for aspirin for dementia reduction. But this was a pretty healthy population, to say. Multimodal approaches. So the FINGER trial has taken a multimodal approach, which looks at vascular risk factor control, as well as lifestyle interventions, cognitive training, showed a benefit at 2 years and is now being expanded more broadly as part of the worldwide FINGERS consortia, which are trials all over the world, really looking at similar interventions that are culturally specific. So for instance, FINGER was a Norwegian study, which was, the dietary intervention. There was a lot of herring and other Scandinavian food that I think is less translatable to other places in the world. So they're looking at this in different areas to sort of really look at culturally specific interventions. So finally, in the last couple of slides, I do just want to make a point that although prevention is important and prevention is what I'm most excited about in terms of impact on dementia, there may be other factors that influence how vascular disease, both vascular risk factors as well as even stroke and subclinical stroke, might contribute to cognitive decline in dementia. So first of all, if you have both vascular risk and Alzheimer's neuropathologic changes in the form of increased amyloid burden. This is an arithmetic study. We see that both independently contribute to dementia risk. We do not see evidence of an interaction between the two, meaning the combination doesn't multiplicatively increase your risk of dementia, but I think we still have a lot to understand in this area. Certainly, we see continued, for instance, hypertension in midlife was still important for dementia risk, even after adjusting for amyloid, which I think is really important in, again, thinking about how we're treating potential dementia cases. But we need to understand a bit more about if there's ways in which these interact at all. Beyond the sort of possibility of Alzheimer's neuropathology or other pathology co-occurring, what about other factors? So Survi Eshrawan, who's a summer student in my lab this summer, and Renee Greshel, who's postdoc with me right now, looked at this in terms of social support of people in the ARIC cohort. So we have, from an earlier ARIC visit, an assessment of how isolated and how supported people in the cohort are, how many people they see on a daily basis, what their social interactions are like. And they looked at the relationships between those social factors and dementia rates, but specifically looking at the potential interaction between those social factors and subclinical cerebrovascular disease on dementia. So we know in general, white matter hyperintensity's other cerebrovascular disease is associated with dementia risk. And the real question here is your social support modify that association. And these are relatively new unpublished data. And basically what we found, so first of all, overall, not unexpectedly, each of these small vessel cerebrovascular markers was associated with higher risk of dementia. We expected that. That was has been shown in some other studies. But people who had more social engagement, sorry, this fell off that row, had less impact of the vascular changes on dementia. So in other words, if everyone has an increased risk of dementia, in the case of microbleeds, if you had high social support, microbleeds were no longer important in increasing your risk of dementia. Whereas for white matter hyperintensities, it's still important, but much less. This is showing you the microbleed relationship. So if you had high support, that may sort of overcome the increased risk that you would get from having microbleeds. I think this is really exciting. Obviously, we want to prevent things at an earlier stage. And this is the huge caveat. This is social engagement decades before the development of dementia. So this doesn't say anything about interventions that can be done once you see someone with microbleeds or white matter hyperintensities, and it's probably reflective of their general social structure, family structure, access to healthcare, et cetera, even though we try to adjust for some of that. But I think it's exciting in thinking about ways that we might modify the risk. It's, we think about cognitive reserve in the Alzheimer's space a lot, which is this idea that you can have a lot of pathology in your brain, but you have factors that protect you from the expected phenotype based on that pathology. And traditionally, we haven't thought about this for cerebrovascular disease, but I think we should, because I think similarly, there may be important factors that make you relatively protected from the cognitive sequelae, both of stroke as well as silent cerebrovascular disease. We didn't see a similar relationship for raccoons for these DTI measures. And then finally, as another sort of example of a modifier of your vascular risk on dementia, Adrienne Tin looked at this, who's at the University of Mississippi, looking at a polygenic risk score for Alzheimer's disease to see how that interacted or didn't interact with vascular risk. And in this case, it's the Life Simple 7, which is an American Heart Association recommendation of how to have healthy vascular status. So a higher Life Simple 7 score is better. In this case, that means you have more ideal cardiovascular health, and low is worse. And basically what she found is that regardless of your genetic risk strata, your Life Simple 7 score was associated with dementia in every strata. So the absolute highest numbers certainly are among people who have a high polygenic risk and a low Life Simple 7 score for cardiovascular health. But we see that cardiovascular health is important regardless of your genetic risk strata. So to wrap up, in conclusion, I hope I've convinced you that vascular risk factors, especially in midlife, are really strongly related to late life cognitive outcomes of dementia, so is stroke. And that mechanistically, it may be that these risk factors act on structural or silent vascular changes in the brain, or even by deposition of amyloid. This relationship between vascular risk factor status and amyloid itself suggests there may be some direct connection, and treatment is that much more important because it could not only be active in parallel to amyloid, but might directly impact it as well. There's not a lot of evidence that preventing any of this actually impacts cognition, but we really don't have studies that have the long-term follow-up, and we won't really have trials that have the long-term follow-up that's needed to understand this well. And then there's other factors that we need to consider as well. There may be other important modifiers, whether genetic or social, or other pathologic processes. So as part of my job as branch chief at the NIH, I get to both build up the branch, but also do some exciting research in my lab, lots of exciting research in my lab. We're continuing to look at some of the interactions between vascular risk and also some of the omics, as well as a lot of social factors. And really, I got excited recently about this concept of cognitive reserve in this setting. Also understanding more about small vessel disease, what patients go on to progress, who goes on to have cognitive problems, and how that overlaps with AD, really thinking about the life course and trying to find a pediatric or adolescent cohort that wants to keep following people and get some real, long-term life course information. And then I can't be here without saying something about the discovery cohort, which you guys all know about. I lead the cognitive and statistics core for this wonderful study led by Natalia Gross and Steve Greenberg, which is really focusing on post-stroke dementia in disparities populations. And again, focusing on this concept of a vulnerable brain that's really important and who goes on to have certain post-stroke cognitive outcomes. So here's just, you've probably seen this slide like 700 times from Natalia, but I'll show it one more time. And then here are my acknowledgements. A lot of this work is incredibly multidisciplinary, and I have great colleagues, and my support is currently the intramural research program at the NIH, but I've had great support previously when I was at Hopkins. And here we are doing various non-work things. And with that, I will stop and hopefully have time for some questions. So thank you very much.
It's amazing. Thank you. It's good to see you study. Just so, and the stroke, they kind of talk about the Alzheimer's. Is there anything there? Or are you studying different cases in the area?
Yeah, so I'm not aware of studies specifically looking at, I don't know, I guess people can hear it because we had a mic on the Zoom. The question was about stroke genetic risk and whether that's associated with cognition, presumably post-stroke. And I'm not familiar with studies looking at that specifically. We generally either look at people once they've had a stroke and see what happens with them afterwards. With the exception of sort of monogenic disorders like CADASIL, and there's other certain conditions that we know are associated with risk of stroke or stroke-like events that are also associated with sort of cognitive dysfunction. So CADASIL is an example of one of the few cases I think of pure vascular dementia. I have a great group of colleagues studying a CADASIL cohort at NIH, which I get to be a part of. And so we're sort of thinking about actually some of the same questions about cognitive reserve. So they just sort of described a family where there's two identical twins who grew up in different parts of the world with CADASIL and have very different phenotypes. Their scans look similar in terms of white matter hyperintensities, but one is much more impaired, the other is still working. So I think that's really cool. But I'm not, that doesn't mean it hasn't been done, but I'm not familiar with work at looking at stroke or genetic risk in particular, but it's a great point. He has the mic, I guess he can say.
Thanks. That was wonderful. I have a medical question, maybe kind of a very question. But if you create a cohort like this, and you tell them you're going to every 2 or 3 years, change their behavior, and are you underestimating perhaps biological effects for people who are trying to do their best, then exercise? And go off for the team every time they show up, or is that a small effect, but so they're relevant?
It's a great question, and the funny thing is, in all the years I've talked about ARIC, no one has ever asked me that question. So congratulations for that. But so you're right. So there's two things. In general, people that come back and are part of a study, even though we randomly recruited them from communities at the start, are different from people who don't. We don't think they're as different as a trial population who may be highly motivated to participate in intervention. So we think they're closer to being representative. we don't, we communicate results back to people. This has been recent amyloid specific therapies. We're very much trying to figure out what to do about, giving results back for our amyloid PET scans, because that's a whole other messy question. But we don't offer other interventions. Actually, with one exception, there's a nested trial that includes ARIC participants plus new recruits called the ACHIEVE trial, which was presented at the Alzheimer's conference this summer, which looked at hearing intervention. So it had people that were screened had mild hearing impairment and were randomized to either hearing intervention versus not. And particularly in the highest risk people found a pretty big benefit of hearing intervention for dementia outcomes. So that's sort of one subset that's getting a specific intervention. And that's obviously a change in how they might do. I don't know. I mean, I suspect that you're right in some ways. I mean, I see this all the time clinically that someone, I'm not doing outpatient now, but when I was at Hopkins, I had a patient who was embarrassed to show up if he knew he had gained weight because his knew his A1C would be back up again. So he would cancel until he felt like he was going to be. So yeah, I suspect that there may be some impact that just the accountability to the study is having. We try to be supportive. We try to give educational materials without being prescriptive. Obviously, if someone comes in and has, first of all, incidental findings, like they get echoes if they have something very concerning, or they have a subacute stroke on their MRI, or their blood pressure is incredibly high, then we have to do something about that in terms of sending them for medical care. But it's a great point. I don't know, there's no great way to study it because the people that are not being studied, like there's no comparison group of people that aren't being part of a study that we have data on. But it's
you observe it.
Yeah, no, but and I don't know if that's the case with anyone that's going to see the doctor occasionally over time, if they're going to make slight tweaks in their behavior, but no, but I think it's a very valid point.
Well, we mentioned that earlier, blocking books, when we associate this fact that it's stroke and dementia. And then we used to go and ask questions about the specificity associated with Alzheimer's versus non-Alzheimer's dementia. Secondly, is there a difference, the risk and non-stroke suffering? Versus the delicate one.
Great. So the specificity of the dementia type, so it's about dementia type and then stroke subtype are the two questions. So in ARIC, we initially planned to try to get dementia subtype and looking at relationships. And when you're implementing any kind of evaluation on a broad scale, so I was in charge of teaching the nurses at all the sites how to do a neuro exam. They were not neuro nurses. Some of these, like the Hagerstown, Maryland site is a pretty rural area, an hour west of DC and Baltimore. And we simply felt that we didn't trust our data enough to make etiologic diagnoses of dementia. So we have information. We have Kaczynski ischemic scales on people at their first ARIC NCS visit at visit 5. And we've looked at that in some studies, but we don't have as much confidence in it. So we generally haven't looked at subtype. My general suspicion is that everyone is mixed pathology. So even studies that are specific and say this is associated with Alzheimer's versus vascular dementia, it's not really Alzheimer's, and it's not. I mean, certainly there is value to assigning a primary etiology, I think, but I think most people are mixed anyways. There certainly are studies that look at the studies that have pathology that link risk factors with pathologically proven Alzheimer's, suggesting that there's, there's several studies looking at circle of Willis atherosclerosis and amyloid and tau, looking at AD staging and finding associations. So it appears that there's at least some evidence that it's specific to AD, but I think in general, it's most sort of all-cause dementia more broadly is what we see for these relationships. But because so many people have mixed pathology, isn't it still important to get at this other aspect of things? In terms of stroke subtype, so in this stroke COG consortium that Deb Levine is leading, we have new unpublished data not showing differences necessarily in stroke subtype and outcome. That being said, we know that in general, cardioembolic stroke patients tend to do worse. trying to understand if that corresponds to an increased risk of dementia. I think discovery is going to really try to answer this. That's one of our main goals, is to try to answer what, not only subtype in terms of ischemic versus ICH and subarachnoid, but specifically ischemic subtype, and which is most associated with risk of dementia. But the closest evidence is sort of suggestive that cardioembolic appears to have a higher risk, but it's hard to tell because people with cardioembolic stroke are older. It's a little hard to fully get rid of the confounding in those relationships. Thank you. Yes.
So those are the middle age who are people. Are there any factors like coffee?
Would you like me to say yes? I don't know. Sure. No, it's the reality is, the general school of thought. I think there's a question up in the way in the back, but the general school of thought is that the most traditionally studied and well-recognized factors that contribute to cognitive reserve, at least in the Alzheimer's world, are education and occupational complexity. Those are well established. You have those in your favor. And I would argue that, you're here in terms of being antisocial. I think, we're worried about the people who are really, really isolated, who might be at highest risk, and are not interacting with others. I don't think, a slight personality preference to hang out with your family and pets instead of other people. But coffee, sure. No, we don't know about coffee specifically. Some studies. I thought there was, oh, there we go. You moved.
Yeah.
Yeah.
It's much better. Yeah. And it's very, what do you think is the role of other environmental risk factors, such as nutrition, collagen and therapy?
Yeah, so there's some pretty good evidence looking at air pollution and stroke, and even some looking at small vessel disease, and so it would follow. So those relationships have been described. Again, tricky in terms of the confounding by urban setting. So people that live in the most polluted regions have other social determinants of health against, not in their favor. So it's hard to fully separate those. You're not going to be able to randomize people to living in a more polluted versus not polluted area. There's some really, I've been having some discussions with other NIH, EPI people in other institutes in the intramural program, thinking about studying this in relation to sort of both over time, looking at climate-related changes, not just in pollution, but in temperature and other factors, looking at disasters and how things change before and after a disaster. That's less about pollution specifically, but another sort of environmental factor. So you're absolutely right. It is likely that there are other influences beyond individual choices in health. And I don't mean to suggest that many of these factors are individual choices, but things that might be out of an individual's control. But they're hard to study independently because they're so confounded by other factors that we know influence health too. But yeah, it looks like we know pollution is important for stroke, and so it would make sense that that's likely related. I don't think it's been looked at specifically carefully with cognitive decline and dementia. We do have some of those measures in ARIC, so we can look at that. I think there's nothing to add. There we go.